Okay, first, the withdrawal of life-sustaining treatments aims to help terminal ill patients to receive hospice care in ICU. In 2009, in Taiwan, the Hospice Palliative Care Act began to address life-sustaining treatment should be withheld or withdrawn for terminal ill patients who meet the criteria for DNR. However, a recent study indicates that terminal ill patients often receive high-intensive life-sustaining treatments. In a global survey, research found the withdrawal rate for life-sustaining treatment in ICU in Asian countries were between 3 and 8%, which were much lower than the rate of 13% in both USA and Europe. The other study also indicates that among the 16 Asian countries, Taiwan is ranked the 15th with very low withdrawal rate of 3 and 4%. A few studies began to look at the impact of life-sustaining treatment on survival in ICU for terminal ill patients. For example, the study found that the cardiovascular collapse management increased short-term survival, but not the long-term survival after discharge from the hospital. The other recent study also found a prolonged higher dose of medication increased mortality rates. So the question is raised: can terminal ill cancer patients benefit from life-sustaining treatments? The recent review studies found that life-sustaining treatments increase short-term survival rate less than 6 months in cancer patients in ICU, but it's not known about a long-term survivals. The recent study conducted in 2018 found the 1-year mortality rate are lower in cancer patients after receiving active treatments in ICU. The review study suggests that not the life-sustaining therapy, but palliative care is suggested for terminal ICU admission patients. However, more studies need to be done to understand the impacts of life-sustaining treatment on ICU and also the long-term mortality rate among the terminal ill cancer patients. Therefore, this study aims to explore withdrawal rates, family acceptance of hospice consultation in ICU, and also the ICU and 1-year mortality rate between the terminal ill cancer patient and the non-cancer patients. The other aim is to explore the impacts of life-sustaining treatment on mortality rate in terminal ill cancer patients. This study adopts a retrospective longitudinal design and a child review method to collect and analyze the 1-year data from January and to December 2016 among terminal ill patients at 4 MICU units with 44 beds in total at a major medical center in Taiwan. The inclusion criteria of the subject is the patient who were diagnosed as a terminal ill patient by 2 specialist physicians and who had already signed a DNR. About the data collection, the data were collected using the RedCap tool. Data is collected including the demographic data, disease data including the primary diagnosis, and also the Apache score, which indicate the severity of disease condition. The final the data collected related to the withdrawal data, such as the duration of ICU stay, hospice care consultation, date of decision and the implementation of withdrawal of life-sustaining treatment, and the death rate during the ICU admission and the 1-year death after discharge. We move on to the results. As you can see from this table, there are 2 groups. One is a cancer group, the other is a non-cancer. They're all the terminal ill patients. As we see from the table, there are 2 significant difference between two groups. The patient in cancer group, they are more younger, and the more cancer patient had marital status with living with partners. For the race background information, such as the gender, DNA status, and the severity score, Apache score, there are no significant difference between two groups. The results about the comparison to group in terms of the withdrawal rate and the acceptance of hospice consultation, as we can see from the table, there are significant difference in the withdrawal life-sustaining treatment in cancer and non-cancer group. We can see the patient in cancer group, they have much lower withdrawal life-sustaining rates than the patient in non-cancer group. As we see from the table, cancer patient, just the 6.5%, they they agree to withdraw the life-sustaining treatment, while the patient in non-cancer group, they are about 14%, they agree to withdraw. About the family's agreement on the hospice consultation care, similarly, we can see the family of cancer patient, they are more refused to receive the hospice consultation care. As noted, we can see the family from the cancer group, near the 50%, half percent, they refuse the hospice consultation care. When we look at the mortality rate between the two groups, we can see there are no significant difference between the ICU stay. So the average they stay for 2 weeks, about 15 or 14 days in ICU. But however, when we look at the mortality rate in the ICU, there are significant difference. As we see the patient in cancer group, almost 70% terminal cancer patient, they die in the ICU. So we look at the ICU days and also the days within the 1 year. We see the cancer group, almost 80%, they are die within the 1 year. It's higher than the patient in non-cancer group. So from these survival figures, we can see the red line indicate the cancer group, the blue line indicate the non-cancer group. So you can see from the ICU admission into the 1 year follow-up, only near the 21% of cancer patients survive more than 1 year. So we try to find out whether the impact of life-sustaining treatment on their mortality rate. So when we look at it within the cancer group, for those patients receive the life-sustaining treatment, they indicated by the red line. From these figures, our study indicates that for the cancer group, for the cancer patient, receive the mechanical ventilation and parenteral nutrition support. Both patients, they had a low survival rate, which means the higher mortality rate than those cancer patients without these two life-sustaining treatments. Move on to another interesting, we found about the enteral nutrition support, such as the NG feeding. We can see for those cancer patients receive this nutrition support, indicate the higher mortality rate within the mortality rate in ICU and also the 1 year mortality rates. There's only one positive impact of the sustaining treatment, which is the cardiovascular collapse. This management is different. It's only provide a positive effect, which means for those cancer patients receive the cardiovascular collapse management, they had a better survival rate within 1 year. Based on the result, this study indicates that only 6.5% of the terminal ill cancer patients in ICU in Taiwan withdrew from life-sustaining treatment. Our withdrawal rates were much lower than the around the 13% report in the Western societies. This study suggests that in Taiwan, most families members of terminal ill cancer patients are unlikely to accept withdrawal of life-sustaining treatments in order to prolong the life. For the cancer patient, the ICU and the 1-year mortality rate were almost 70% and 2.3%. Study shows that the majority received intensive life-sustaining treatment. Only near the 21% survived more than 1 year. Our mortality rates were comparatively higher than those reported by the previous study analyzed 84 countries. Indicates that ICU mortality rate of 72 or 1-year mortality rate is 23.8. So we can see for our study, our mortality rate in the terminal cancer patient much higher than the previous study. This study indicates that receiving the enteral nutrition support, such as the entry feeding, significantly increased the ICU and 1-year mortality rate among the terminal ill cancer patients. Feeding might be considered by family members as a fundamental supportive care for the patient, and also as a way of expressing filial piety in Chinese societies. The value of filial piety based on Confucian teaching influence adult children's caregiving behaviors, which emphasize the novel treatments to prolong life for their parents at the end of life stage. According to a study, the implication of this study in our study, the majority of Chinese family members prefer using ICU treatment to prolong the patient's life, and most families are reluctant to receive the hospice consultation care. Therefore, we suggest in the future the training program for professionals need to conducting cultural sensitive communication about the good days with families, assessment of the impact cultural value on their end of life decision, allowing the cultural practice and the ritual by traditional healers, allowing the families to participate in direct care in ICU, and provide the bereavement care for family members. In conclusion, majority of family members reject the withdrawal of life-sustaining treatments to prolong the terminal ill cancer patients. According to the finding, urge to develop a family center with cultural-sensitive hospice care program in ICU, especially in the Chinese societies, to improve cancer patient quality of life and die in peace. Thank you for your listening.